So, hi everyone. I wanted to welcome you to our session this evening with Dr. Holzberg. My name's Jyothi. I work with the Zio Plus, and one of the brands you're probably familiar with is Utiva. And I just wanted to quickly give just a brief outline of what the evening will look like. So, we are going to do just a few minutes of introductions, and then we'll move into the presentation. We'll leave about 15 minutes at the end for question and answers. So anytime you have a question, just feel free to add it into the chat or the Q&A, and we will just make a note of it. And then at the end, we'll do our best to get through as many questions as possible. I just want to also note that the webinar is going to be recorded. So a few days after today, we'll send out the replay through your email, so you can look out for that. And I think that's about it. Oh, right. And I just wanted to mention we do have a raffle for the 2 Amazon gift cards. So at the end, we'll do like a quick live raffle. So just be sure to hang on. So if we mention your name, you can just say that you're here. And then after that, for anyone who is interested, I'll hang on to just do a quick product presentation on Utiva if you're interested, but that will be beyond the 8:30 mark. And with that, I just wanted to introduce Dr. Holzberg. So Dr. Holzberg is a urogynecologist with over 25 years of clinical experience and 15 years in physician leadership, currently practicing at Inspira Medical Center in New Jersey. He has held several roles, including a chair of OBGYN at Rowan University and division head at Cooper University Healthcare, and has contributed to research and education through national and international lectures. A founding board member of International Healthcare Volunteers, he is dedicated to advancing women's health globally. Dr. Holzberg is a board-certified OB/GYN and urogynecologist and has recently been honored as a top doctor by Philadelphia Magazine and is known for his patient-centered, compassionate approach to care. So thank you so much, Dr. Holzberg, for joining us this evening.
Yeah, I appreciate the invite and excited to talk to you all about this topic. Some of you may have, I've done a couple of previous talks about Utiva. One of them was a more straightforward kind of UTI, recurrent UTI talk, and the other one was more talking about empathy and compassion. So Jyoti had the great idea actually of taking those two topics and kind of bringing them together. In addition to my clinical work, just for full disclosure, I do a large amount of consulting work for a large healthcare consulting firm here in the States that does international work as well. So I do spend a lot of my time with providers and healthcare systems to improve the communication that physicians have with their patients and show them a lot of what we're going to talk about today, that things like empathy and compassion don't have to be something that's naturally innate to you. They can be learned. So we're going to talk about that today in addition to some recurrent UTI stuff. So I appreciate everybody taking the time out of their evenings to join. And we're going to talk about something that we all deal with constantly, in all likelihood, for many of us that are in the primary care arena, and whether you're an OBGYN, a primary care physician, a urogyn. But rarely do we dedicate time to think about it strategically. And recurrent UTIs are a problem that patients are dealing with, unfortunately, on a fairly frequent basis. So before we jump into the talk, I want you to meet Sarah. So Sarah's 42. She's presenting with her fourth UTI in 6 months. You've all seen this patient. She's frustrated. She feels that she's been dismissed at this point. She's losing faith in the care that she's receiving. And in each visit, she gets the same thing, right? She gets a UA, a culture, an antibiotic. See you next time, right? That's what keeps happening. So what I want to challenge us today is whether we're leaving clinical value on the table, right? Both in what we prescribe and in how we have that conversation with our patients. We're going to talk about the 2025 AUA guidelines, which gives us new tools, the cranberry evidence that has matured significantly of late, and the data on the empathetic communication and adherence is really hard to ignore. And we're going to talk about how being more empathetic really has tremendous effects on adherence to some of these therapies. So for the next 40 minutes, we're going to talk about how we could do better for Sarah. and the millions of patients just like her. All right. So let's get a little bit into some of the epidemiology. I'm going to be brief. I know these numbers, are things that you probably know, but let's frame the urgency of this matter, right? 150 million cases annually worldwide. That's the estimate, probably more than that. A quarter to a third of women experience recurrent E. coli accounts, which accounts for 75 to 90% of these UTIs. So it is most commonly E. coli, and especially in recurrence. And that's not new, obviously, to anyone here, because if we're all doing our UAs and cultures on these patients, we're seeing the E. coli show up. But this number, right, these numbers should give us a little bit of pause because half of these patients perceive their healthcare experience as lacking compassion. So if you look at the last statistic there, 50% perceive that we're not being compassionate enough. And that's not from some survey at a spa. That's peer-reviewed data. That's data looking at patients in real life healthcare settings. So when you think about recurrent UTI, and that population specifically, women who keep coming back, who feel like nothing's working, the number's probably worse, right? So it may be 50% overall feel that they're not getting compassionate enough care. My guess is in recurrent UTIs, much, much more. So here's why the timing matters, right? We're facing a rising resistance with fluoroquinolones, with trimethoprim sulfamethoxazole resistance, and these rates and the satisfaction of the patients, right, in the care we're giving them is declining. So our resistance is going up, and their satisfaction is going down. So we're at kind of a critical point where women keep coming back, but they feel they're not getting the care they want. So we're going to talk about the old playbook, right? Was kind of give empiric antibiotics, a follow up if they need it. That's just not going to work anymore, right? The new AUA updates think of it as in a different way, and I think gives an opportunity for primary care physicians to get even more involved. You don't have to be a specialist to take care of these patients, and I think the AUA guidelines purposefully did that in order to empower the primary care physicians to be able to take care of these patients. Well, all right. So what we're going to talk about today. So here's the roadmap, right? We're going to kind of it's going to be in let's see, what is it? 5 different sections for about 4 or 5 sections, right? First, we're going to do a quick review of the pathophysiology of recurrent UTI. I'm not going to get deep into Micro 101, but we're going to talk about some specific mechanisms. And the reason I'm going to talk about it is because you can use that information in your conversations with your patients. Then we're going to talk about the AUA guidelines and the update and what the shifts are. And in particular, we're going to talk about how cranberry is now a strong recommendation. And the strong evidence behind non-antibiotic therapy, that there's many other therapies we can use beyond antibiotics. Then we'll talk about the communication piece. And I know some of you are like, that's kind of soft, kind of skeptical about all of this communication stuff, but there is good data about empathetic communication. It's surprisingly quite robust. And then we'll put it all together and in a kind of a practical framework for you to kind of take to your patients, right? I'm not gonna make it so you have to spend 45 minutes with the patient over the recurrent UTI. I'm gonna kind of frame this so you can take one of your 15-minute visits and do everything that we're going to talk about today. So let's talk about recurrent UTIs and kind of simplify it the best we can. So why recurrence, right? We all understand kind of the basic microbiology, but what occurs, the intracellular bacterial community, right, concept is worth reviewing because again, it's something you can simplify and explain to your patients why they're getting these recurrent UTIs. So E. coli, which we talked about being the most common reason for recurrent UTI, they don't just colonize the bladder lumen, right? They don't just sit there, right? They have what's called type 1 pili, which are little kind of fingers that invade into what's called umbrella cells. And they form what's called IBCs, intracellular biofilm-like communities, right? So these evade innate immunity, so the body's just own ability to fight the E. coli and the antibiotic penetration. So these IBCs, right, that are created with the E. coli in them don't get affected by the antibiotics. That's why these patients get colonized. And when the superficial cells exfoliate, The bacteria then reemerge, and then the cycle starts again, right? So this is why a standard 3 to 5 day course of antibiotics, it'll clear the symptoms, but it doesn't eliminate the reservoir. And this is the part that you could explain to the patients. Like, yes, your symptoms are better after antibiotics, but the bacteria is not gone. And that's why the symptoms go away, but then a period of time later, the E. coli reemerges and causes the symptoms to come about again. So the drug isn't able to reach the target, right? So you layer on top the host problems, right? The patient problems, right? The estrogen changes in the vaginal microbiome in postmenopausal patients, the incomplete emptying, the postcoital mechanics. You have all of these multifactorial problems that demand not just antibiotics, right? They demand a multifactorial solution. So I find if you can frame it in this way to patients and set the expectations that look, patients will say, I want antibiotics, I want antibiotics, I want antibiotics, but you have to explain to them it's not going to make everything go away. We have to be preventative, right? And the prevention strategy, you have to explain to them the prevention strategy is a key part of successfully reducing the number of UTIs in recurrent UTI patients. Okay. So we're going to do a little bit, we're going to do some polling today. So the first poll talks about initial management. So when a patient presents with recurrent UTIs, that's greater than or equal to 2 in 6 months, what is your typical first step? A, treat with another antibiotic. B, send urine cytology and wait to adjust therapy. Um, C, discuss prevention alongside treatment, or D, refer early to a urogynecologist or urologist. So if everybody can answer that poll, we'll get our data. Are we good, Yoti? Are we getting the data?
Yeah, we have 60%
Okay.
participated, so
Yeah, we'll give
we'll
it some
end it
time.
now.
I can't see it. I can only see the question, actually. Yeah. There we go. Now I
Okay,
can see
there you
it.
go.
Yeah. All right. All right. So we're getting some more people to participate. So far, we discussed prevention alongside treatment, which is great.
Do you see the results, Adam?
I see. I don't see it changing. So I'm just
Oh, it's
seeing
done now.
one. Yeah.
It's
Yeah.
done now, yeah. These are the results.
Are these the results you have? Yes. So
Yes, yes.
50%. So 50% say discuss prevention alongside treatment. About 43% say send urine testing and wait to adjust therapy. About 5% say to refer out, and then 2% treat with another short-term antibiotic. Okay, great. All right, so that's good. That's actually encouraging, right? That we have people talking about some prevention strategies. So let's talk a little bit about the AUA guidelines. There's been basically, I can kind of narrow it down to three major shifts in the updated guidelines that have direct practice implications, right? First is patient-centered risk management. The guidelines want us to consider individual complicating factors, not just putting patients into two categories of uncomplicated versus complicated. That was the old AUA guideline. Now it's important because this changes the intensity based on the actual patient in front of you. So we're looking at the actual patient and their complicating factors. Second, antimicrobial stewardship, right? So we should be aware of the resistance within our own communities, particularly for fluoroquinolones, which are approaching 30% in some communities. So we need to be good antimicrobial stewards to try to reduce as much of that resistance and be aware of what the resistance is around you because it's going to be different. Third, we need to, which is the most relevant to what we're talking about today, is the non-antibiotic prophylaxis is formally endorsed now, right? Cranberry products with an adequate amount of PAC, methenamine, increasing fluids are now in the guidelines. So now we have true recommendations, not just kind of what people used to say was a little empiric. And that's a significant change from even just 5 years ago. So this reclassification is worth noting, right? Localized versus systemic replaces uncomplicated versus complicated. So symptom resolution replaces It used to be sterile culture meant that was your endpoint. You now have a sterile culture. Now it's if the symptoms are gone, you treated them adequately. And if you have a negative UA, that rules out UTI. Okay, so that should reduce some unnecessary antibiotics. If they have a negative UA, even without a culture, you can tell the patient they don't have a UTI. So this is the general kind of in a nutshell changes. Now here we could kind of, and I'm not going to drain this slide and I'm not putting it up here so that, but it is something you should look at. This is kind of a visual summary of what the framework is now for the new AUA guidelines. So the key shift is away from an algorithm management and more towards, like I said before, an individualized risk stratification. So for your recurrent UTI patients, this means that management plan should reflect their specific risk profile. Are they menopausal? Are they sexually active? How sexually active are they? What types of sexual activity do they have? The anatomical factors, right? Prior antibiotic exposures. You need to look at them specifically, not just kind of put them into, generic categories. Under the old framework, Sarah would get another script, right? Another empiric script. But under the new framework, we're prompted to characterize her risk, right? Consider prevention first, engage her in the treatment decision, right? Which is what we're going to talk about a little bit, but engage your patient in where we're going to go. And that lets us look at the treatment. So let's see what treatment specifics are. Now we listen, antibiotics are still the key way to treat a UTI. So I'm not trying to say it's not. So the first line are familiar. We should all be familiar. Nitrofurantoin for 5 days, fosfomycin single dose, trimethoprim or Bactrim, trimethoprim sulfamethoxazole for 3 days, right? Nothing new or revolutionary here, but a few practice pearls that might be worth thinking about. Like I already talked about, the antibiogram, right? Guided selection is critical. If your health system publishes local resistance, use it. You can ask your infectious disease area or your pharmacy or somewhere, do you have antibiograms? And you'll be able to actually get the resistance within your area. Empiric trimethoprim sulfamethoxazole in a community with 25% resistance isn't evidence-based, right? It's just a habit of what we always do. We just always give that drug. So the emphasis is on shorter durations. That is a little bit of a change. Shorter durations are intentional, not doing these 7-day, 10-day regimens, right? Because collateral microbiomes damage scales within the exposure time. So what that means is we're not helping anybody with 7-day courses for a localized infection, right? We want shorter courses are going to help prevent that patient's microbiome from being damaged, right? And increasing that resistance. Self-start therapy should still be considered in the right patient that's reliable, that's going to go get their culture prior to starting those antibiotics, because it's okay to have their own script, but we'd rather them get a culture first and then start the script. And it reduces that time to treatment and it empowers the patient. It makes them part of helping them, not just being done to them, but being done with them. So my main message is treatment protocols are table stakes, right? The real practice gap is prevention. And that's where we should be spending some of our time during the visit. All right. So let's go back to Sarah for a second. 4 UTIs, 4 courses, right? Nitrofurantoin, Bactrim, fosfomycin, and then back to nitrofurantoin, right? Each course provides symptomatic relief. I mean, she had symptomatic relief with each course, but progressively it disrupted her gut microbiome and her urogenital microbiome by giving her all these antibiotics. We all know that the collateral damage that happens with antibiotics, our infectious disease specialists will tell us. Your lactobacillus goes down, your candida overgrows, the resistance goes up. And recurrent UTI patients specifically, antibiotics can actually paradoxically increase recurrence risk by depleting the protective flora, right? Because by depleting the good bacteria, you actually may be putting them back into a cycle of recurrence. So we have to be careful about the amount of antibiotics we use. So this is critical. This is a clinical inflection point, right? Sarah's frustrated, right? We're running out of first line antibiotics. We've given her everything already. We went back to nitrofurantoin after starting it. and we don't have a prevention strategy. So this is a cycle that has no good endpoint. You're just going to continually have the UTIs to come back, and Sarah's going to be frustrated, and then you're going to get frustrated, and it's not a great situation. So let's talk about what the evidence says we can do instead of this. All right. So before we dive into that, let's do our next poll. How often do you recommend non-antibiotic UTI prevention strategies? Rarely, occasionally, frequently, almost always. Non-antibiotic UTI prevention strategies.
Okay, I'm gonna let it get to 60% participated, and then we can launch the results. Perfect.
All
Okay,
right.
results are up.
So frequently won, 38% said they frequently recommend non-antibiotic therapies. Um, Next was almost always at 32%. So between those two, frequently to almost always was the majority of the group, occasionally 23%, rarely 8%. Great. Well, I appreciate everybody participating. Again, reflects what we talked about earlier. Um, in the previous poll. All right, so let's talk about some non-antibiotic prevention. So here's the evidence summary, and I think the numbers make kind of are stronger than many of us might have expected, right? Cranberry products, right, with at least 36 milligrams of Pax have a 20% risk reduction in adult women. 20% risk reduction of UTI in adult women. In a pediatric population, actually, it's even higher, 54%. In post-procedure patients, after they've had some sort of procedure, 53%. And these are from meta-analysis. This is not from a single, center. This is from looking at multiple trials and putting them together. So this is pretty good evidence. Methenamine, which is being more and more recommended and used, 35% reduction. Um, and I think, like I said, this is fairly underprescribed. I'm even using it more of late than I did before. Even simple increased fluids give a 10% reduction. So telling patients increase their water intake, right, is really important. So the guidelines are clear, right? Offer these before antibiotic prophylaxis, right? Before we're going to give patients daily or, with relations or whatever we're going to do and have them take any sort of regular antibiotics, we want to offer these options before that. Also, vaginal estrogen for the postmenopausal patients. We're going to discuss this in more detail in a second. And it's actually arguably the most impactful way to help prevent urinary tract infections next to cranberry. So the clinical advantage is obvious, right? No resistance, no microbiome disruption for the patient, no adverse drug events, right? Population has already been hammered with antibiotics, right? This should be our default approach. We should be starting with this. Combination strategies like this are additive to antibiotics, and we need to be more data specific on how we use the combination. So we're going to go into our third poll for a second before we talk about estrogen. So for peri or postmenopausal women with recurrent UTIs, how often do you discuss vaginal estrogen? I'm actually more curious about this question than any of them. Never, rarely, sometimes, routinely. Because I know we have a lot of primary care providers here, clinicians, I should say. So I'm curious how often you truly discuss and will use or prescribe um, vaginal estrogen. Routinely. Great. 54% routinely. And then 20% sometimes, 20% rarely, a little under that, and then 9% never. Great. Well, that's very, very good to hear. What a great group we have. So let's talk a little bit about vaginal estrogen. Okay. Effect is pretty striking, about a 50% reduction in recurrence versus 5% with placebo. So that's pretty clinically meaningful. The mechanism, pretty straightforward. Postmenopausal estrogen deficiency leads to elevation in vaginal pH, lactobacillus depletion. That's what happens in a postmenopausal estrogen deficient patient, which then facilitates uropathogen colonization. So vaginal estrogen reverses all that, right? Restores the lactobacillus, normalizes the pH, and recreates that mucosal barrier, that micro, that barrier that prevents that bacteria from ascending into the bladder. So safety data should make us comfortable prescribing it, right? Low dose vaginal preparations, they could be creams, rings, tablets. They have very little systemic absorption, right? And then serum estradiol levels have been looked at. They remain low. Um, so there really is very little systemic. This is not hormone replacement therapy. This is localized vaginal estrogen. So it's how you have the conversation. I say to my patients, when you take a steroid cream versus a steroid in your mouth, right? You're not going to get systemic steroids by putting some hydrocortisone cream on your skin, right? This is kind of the same thing. So you have to explain it to them in a way that they're going to understand, because all they're going to hear is estrogen, estrogen, estrogen. I'm going to get cancer. I'm going to get this. You have to tell them the package insert for oral estrogen is the same as it is for vaginal. So if they're a package insert reader, it's going to talk about the risks of oral estrogen. Although, as we all know, and I'm not going to get into that talk, hormone therapy is making a resurgence, thankfully, because of kind of misreading data many, many years ago. So that's a good thing. So the fix is simple framing, right? Explain to the patient it's local treatment to the vaginal tissue, similar to a topical anti-inflammatory or some other topical cream that's not getting in systemically. So I think if we frame it correctly with our patients, I think they'll be more receptive to it, and it can be very, very helpful in the postmenopausal patient, especially with recurrent UTIs, besides all the other ways it can help patients. All right, so let's talk about cranberry, right? Why we're all here. So let's spend a minute with about cranberry to understand what makes, what will make you either more likely to prescribe it or have a better understanding of using it and recommending it. Um, so A-type packs, right? I'm not going to proanthocyanidins, but I like to say packs because it's a tough word to pronounce, specifically inhibit type P fimbriae, mediated adhesion of E. coli to uroepithelial cells. So it's most effective for E. coli, which is the most common cause for recurrent UTI. It's the critical initial colonization step, right? It blocks adhesions. You interrupt the infection cascade at its origin. That's why it can be so helpful. This matters because it's fundamentally different than antibiotics. We're not killing bacteria with cranberry. And dealing with resistance. We're preventing the host pathogen from interacting with with the patient, right? Or with that bladder. So that's how it helps. It prevents the fimbriae of that E. coli from adhering. And if we go back to like the micro that we talked about earlier, it doesn't form those IBCs in order to live in the bladder where you're symptomatically helping the patient and with a dose of antibiotics, but then that bacteria that's there is just going to reinfect them. Being more prevention like with the cranberry is going to help that not happen. So that's really the mechanism of action. It's blocking those fimbriae from sticking to that bladder and creating those IBCs. So this brings us to the specific kind of product questions, right? Because when we recommend cranberry, the patient's going to say, well, which one should I take? Or I got one at the, here in the US at the local Walgreens or whatever. So Utiva delivers 36 milligrams of packs, the threshold supported by clinical trial data, right? The data has proven that this is what is needed to be effective. And the quantification of whether a product has that amount using the DMAC A2 method is what's been validated and considered the analytical standard. And this is what Utiva uses. Many commercial products, right, don't report the PAX content at all. And if they don't, then we don't know how much it has, or they use older methods. There's a BL DMAC assay, and this can actually overestimate actual PAX. So it's important for you to explain to patients that if you're going to use a product that has 36 milligrams, in the product you're going to recommend that they're using the appropriate method to measure the amount of PAX it has. Because just because it says 36 milligrams of PAX, if they use a method that's an older method that is not accurate, you may actually not have 36 milligrams of PAX. So you want to make sure that the product you're recommending is doing it the right way. So an 18% risk reduction at 36 milligrams is probably a conservative number, 18 to 25%. Combined with behavioral modification, vaginal estrogen where indicated, you're building a really effective prevention program, right? And then add in there increasing, their water intake, and the safety profile makes it easy to recommend, right? Maybe some mild GI symptoms in a small amount of patients, really no drug interactions of any significance, no vitamin K content for your patients to worry about that are on warfarin. So there's really no downside to doing this, really all upside. So let's talk a little bit about Utiva, right? One capsule daily, same time every day if they can, around the same time, pretty straightforward, right? 36 milligrams of packs per capsule, verified with the appropriate method, the DMACA2. We said no vitamin K, trace oxalates. It addresses really the two most common questions you're going to get from pharmacists and patients, right? Um, you know, what should I take? Is it safe? All those things. So the practical tip: patients who can't swallow capsules, right? If they're unable to swallow it, you actually can open up the capsule, mix it into a liquid. Some patients just can't swallow the capsule. So it's good to know you can do that. So Utiva really fulfills everything we want, tested appropriately, the right amount of packs, no vitamin K, trace amount of oxalates. You can open the capsule if they can't take it orally. I mean, so it really fulfills everything we want. So let's go back to Sarah's prevention strategy and look at how we could do it in actual practice. So daily Utiva, increase hydration, 6 to 8 glasses a day, post void habits, right? Complete your emptying, double voiding if you need to. Some lifestyle modifications, maybe some post-coital voiding, breathable undergarments. Not sure how much that's going to help, but sometimes people recommend that. But the plan is only good as the conversation you're able to have with them to build it up, right? So we discuss the evidence for each intervention, right? That's critical. We ask Sarah which one she's willing to commit to, right? Maybe not everything, right? So we talk to them and say, what Sarah, do you want to commit to doing to try to help prevent your recurrent UTIs? If you make it a shared decision-making process, it isn't just it really helps to make her compliance more successful, right? It's a compliance tool by making it a shared decision process. It sets realistic expectations. That's key, right? 26% risk reduction is meaningful, but it's not a cure. So you have to be honest with them. This is not going to be the be all end all cure of all your recurrent UTIs. It's a combination of things that you have to do. So you have to be honest with them, right? This should reduce your episodes, but may not eliminate them entirely. You have a 3 month follow up with them. You explain to them that you want them to do this for 12 to 24 weeks. And this is where the relationship starts to shift, right? From reactive to proactive, right? And it's the bridge to the second part of the discussion today, right? And when you start to bring them into the decision making process, this is where we're going to start to talk a little bit about the empathy and compassion part of it. So let's do our fourth poll. During recurrent UTI visits, how intentional do you address a patient's frustration? Do you A, I mainly focus on diagnosis and treatment? B, I acknowledge it briefly if time allows. I routinely validate the experience and expectations? Or D, I defer those conversations to follow up? So during recurrent UTI visits, how intentionally do you address patient frustration? We want honest answers. Not that I wouldn't think you'd do differently, but
And it's all anonymous.
and it's all anonymous, correct? Don't give me the answer I want. Give me the answer you actually do. All right. I routinely validate the experience and expectations. 71%. Wow. That's great. That's great. 18% say I acknowledge it briefly. 11% say I mainly focus on diagnosis and treatment, and 0% defer those conversations to follow up. So that's good. All right. So let's talk a little bit about why empathy matters. So, empathy in medicine can sound like a bit of a soft topic, right? I get that a lot, especially when I'm speaking with clinicians. So, let me start with the data. So, systematic reviews of randomized trials show that empathy communication shows measurable effects for pain reduction, anxiety reduction, and satisfaction. And those are probably just modest, right? But look at adherence. I mean, look at that green bar. With a 0.42 standardized mean difference, that's not modest. In clinical terms, empathetic communication is one of the strongest predictors of whether a patient is actually going to do what you recommend, right? Because you can say all you want what you think is the best, but when they go home, many of them, based on the experience they have during that office visit, will either do or not do what you recommend. So for recurrent UTIs, prevention specifically, right? This is where it's directly relevant. Every intervention we discussed, cranberry, hydration, vaginal estrogen, requires a fairly sustained patient behavior. They have to really do something. And the best evidence-based prevention plan is worthless if they don't do it. So physicians scoring higher on validated empathy measures achieve much better outcomes for pain intensity, functional disability, and quality of life. And 65% of patient satisfaction variance is attributed to physician empathy. So it really does make a difference how empathetic we are with patients. There's no adverse events found, right? Zero cost. It's evidence-based, right? And it will have significant efficacy on everything else we recommend to them. So it really does matter. So let's talk a little bit about the compassion crisis we might be in. And here's the sobering data. In a study of compassionate moments in primary care encounters, and this is so genuine compassion was documented in about 1% of interactions, right? 70% were missed opportunities, meaning, and the way this study was done is there was an outside observer looking for compassionate moments during the interaction. And they then, while they were observing, they analyzed the opportunities that were given to the provider to be compassionate. So 70% were missed, right? Only 1% actually had genuine compassion. 29% were neutral. I'm not saying we're bad people, right? We went into medicine because we were compassionate, right? That by definition, becoming a clinician means we are compassionate, right? But we're very overwhelmed, right? We have time pressures, we have EMR demands, we have documentation burdens, we have a cognitive load of all the complex problems we're dealing with, right? The system works against us, right? But for recurrent UTI patients, this really makes a difference, right? These are women who have been through multiple visits, multiple antibiotics. They often feel like they're not being taken seriously, and they are the prime people for disengagement, right? So the encouraging finding is that compassionate care doesn't require a lot of time, right? Because the first thing you say is, I don't have time to do this in my 15-minute visit. Well, I'm going to prove differently. It requires you being a little intentional with your technique, which is a learnable skill. It doesn't have to be a personal trait. Oh, I'm just not like that. I don't have that kind of bedside manner like that person does. It can be learned, right? So think of it as a clinical competency, like, I don't know, motivational interviewing, right? So it's something that we should be competent at as a clinician. All right. So, three outcome domains where evidence is robust, right? Recovery from URIs to post-surgical hearing. Perceived compassion correlates with faster recovery. That's what the data shows. The proposed mechanism involves cortisol-mediated immune modulation through causal pathways still being characterized, right? So the study is looking at the biomedical effects of being compassionate, right? Complications in diabetes literature. Patients with high empathy providers or clinicians have significantly fewer metabolic and vascular complications. The adherence pathway explains most of this, right? They're more likely to take their diabetes medicine and they're more likely not to have complications as a result. Adherence, we've talked about already. Patients who perceive a genuine partnership are more likely to take their medications or lifestyle changes or return for follow-up. There's actually an interesting neuroscience footnote, right? They did MRIs on these the MRI data shows that compassion activates reward circuitry in the provider's brain, right? So it actually might be protective against burnout. Two great books I recommend that talk about the science behind compassion and its effects on the giver and the receiver. As far as the benefits on the receiver, a book called Compassionomics, you can look it up and get it. And then another one, the follow-up book by the same authors who I spend most of my career working with. I have no reason to gain from you getting these books, but it does explain a lot of what I'm talking about. Compassionomics, looking at the benefits from the receiver, and um, oh my God, I'm blanking on the follow-up name of the book. Compassionomics, and I'm going to think about it. It'll come back. It'll pop back to me in a second. But the evidence shows that it's not just beneficial. A Wonder Drug. So Wonder Drug is the follow-up book. So it's not just beneficial to the receiver, but also beneficial to the giver. So let's talk about some specific things we can do differently. Active listening, right? Practical technique. It's not a skill, it's not a character trait. It's easy to be trained to do it. The evidence shows you have to look at the patient, right? Attend to their nonverbal cues. Body language often tells you a lot more than just the chief complaint, right? So use reflective statements like say things like, so what I'm hearing is that the recurrence is affecting your quality of life more than the symptoms themselves, right? Takes 3 seconds to say that, that comment. I can only imagine how frustrating this is. I want to work together with you to see how we can improve or reduce the amount of episodes, right? Just those statements are going to show them that you're going to partner with them, you're going to do it together. You have some empathy and feeling and compassion into what they're going through. The data shows the interruption data is very humbling, right? And I'm probably the most guilty at this. We interrupt our patients a lot. Clinicians often interrupt their patients after about 18 seconds. So let them finish. Let them finish their sentence. Wait for the question mark or the period before you then talk. That additional time maybe takes another 30 to 60 seconds, right? The screen issue we all know with EMR. Um, I know we all need to document, but try to have as best eye contact as you can. If you do these three things, right? The active listening, some of the body language, recognizing their body language as well as your body language, trying not to interrupt them. This probably takes 1 to 2 minutes to do during an encounter. One statement, looking them in the eye, giving some sort of empathetic statement. Probably takes 1 to 2 minutes. Okay, so let's talk about some other communication techniques. We're going to talk about 6 specific techniques. Acknowledge emotions, right? I can understand how exhausting this must be. The cycle, right? You're not solving anything by saying that, but you're showing them and you're signaling to that patient that it's not just the culture result, right? There's more to it. Share the power. We talked about that, right? 3 evidence-based approaches, right? To how we can help you and which we're going to talk about the one that's going to best fit your life. Give some autonomy. You'll get more buy-in, right? Check their understanding, right? What's called teach back, especially in your elderly patients, right? I say to patients all the time, okay, so when your daughter or son calls you later to say what happened at the doctor's visit, what are you going to say? Not just saying, well, tell me what we talked about today. That's a little intimidating. But telling a patient, when you tell your, especially the elderly patients who might have more difficulty kind of understanding, say when you talk to your daughter or son, what's the plan, right? That's a great way to do teach back. Clear language, avoid the jargon. That's really important, right? Provide some hope, right? Temper realism, right? We have more tools now than we've ever had before. And if we can work together to do some of these prevention strategies, I think we're going to make a good dent into making this better. And obviously, like I said, using the partnership language, using we're going to work together. So 5-minute connection strategy, right? I know you have 15 minutes. So here's kind of a framework you can do in that 15-minute visit, right? Minute 1, personal connection, right? You may have written something in your previous note, how is your daughter's soccer season going? Or what I do very often, which believe it or not makes an amazing connection. Well, I look at their date of birth. If they've had a birthday either recently or since the last time I saw them, they've had a birthday. I say, oh, so you've had a birthday since I last saw you. I mean, they love that. That's a personal connection, right? Minute 2. validate the emotional experience. I know this has been incredibly frustrating. I want you to know I'm taking this seriously. Minute three, right? Collaboration. What's most important for you today? Alongside your clinical priorities that we do have to talk about during this visit, what else is most important, right? That's going to kind of prevent you from kind of walking out the room and having what we call a doorknob moment, right? Where your hand's on the doorknob as they're kind of telling you one more thing. Minute four, shared decision making. We've talked about that. Minute five, confirm understanding, right? We talked about the teach back, right? So 5 minutes of structured intentionality. That's all it takes. It doesn't cause your visit to go from 15 minutes to 45 minutes, right? And then the remaining 10 minutes could be for your actual clinical care you have to give them. So 3 to 5 minutes on some of this empathy and compassion, with the rest of the time talking about what you have to talk about with their medical problems, is going to make a huge difference in how the patient perceives their visit. Okay. So let's talk about Sarah's. In the old model, Sarah felt rushed. She received a prescription. She had no discussion about prevention. She left no more hopeful than when she arrived. The likelihood of adherence to anything we recommend is probably pretty low. In the new model, we acknowledged her frustration. We explained the recurrence mechanism a little bit in simple, non-jargon terms. We reviewed the evidence for cranberry, and we asked which options we think would best fit her life, right? We use partnership language, and we set up a follow-up, right? Sarah leaves feeling heard, informed, motivated. She's not just a passive recipient of what you're doing to her, but you're working with her. She's an active participant. The clinical difference, she actually takes the Utiva that you recommended. She actually increases her hydration. She comes back and doesn't miss, or no show her appointment. And she now trusts the plan and the person that's behind it. That's the difference you're going to see in some of this. It seems like, wow, I can't imagine that's going to happen, but you'd be surprised. And what that's going to result in is a huge reduction in the repeat visits, right? They're not going to be coming back over and over and over again. From 4 episodes at baseline to 1 by 9 months, that's achievable with all these prevention strategies. And that's going to result in the reduction of their visits and a reduction in their recurrent UTIs. So here's where the clinical and the communication pieces converge, right? Patients who perceive a partnership, maintain prevention strategies, result in reductions in their recurrent UTIs. The empathetic communication we discuss is real. It has real data behind it. And the downstream benefits are huge. So some practical implementation, concrete, step one, any women with 2 or more UTIs, discuss non-antibiotic prevention, make it a hard stop in your practice, make sure it's not an afterthought, prescribe Utiva alongside the behavioral modifications. Step three, set expectations, 12 to 24 weeks for full effect, 26% reduction in recurrent UTIs. Step four, integrate your communication techniques. Step five, schedule a 3-month follow-up, right? That's what you're going to be able to do in your visit, especially in this type of recurrent UTI visit. Be clear about non-antibiotic therapy, right? Define the roles for prophylaxis. We're going to have to do antibiotic prophylaxis at some point. When all of this doesn't work, you're going to probably have to do it, right? So do it over 6 months, right? 3 to 4 episodes annually. Maybe you do it intermittently. I do it, for a month, 2 months, and stop. If we have to start again, there are going to be patients that require it. The key principle is exhaust non-antibiotic therapies first. That's really the key message I want you to get from this. When you do prescribe prophylaxis, frame it as a shared decision again. Quality of life impact should weigh alongside clinical judgment. Okay. So it's not that I don't think we're going to need to do prophylactic antibiotics, but I think we should try non-antibiotic prophylaxis first. So key takeaways from today: 2025 AUA guidelines ship towards antimicrobial stewardship and patient-centered care. Prevention, right? Utiva 36 milligrams of PACT as first-line non-antibiotic prophylaxis. Communication, active listening, right? Aren't soft skills, partnering with the patient, appropriate follow-up at 3 months. I think this is what you want to get out of this talk today in general. So I think we've transformed the patient's journey, right? We've spent years treating recurrent patients with just antibiotics. The 2025 guidelines really give us some good prevention evidence, and communication data points all point in the same direction. It's chronic. It's a challenge. These are challenging patients. I get it. I'm a urogynecologist who sees many of these patients every day. But the tools we discussed today, like cranberry, vaginal estrogen, behavioral modification, empathy, empathetic communication, shared decision making, all of this combined together is what's going to really change the clinical trajectory. It's not going to take a heroic effort. It's not going to take a lot of extra time. Um, so I appreciate everybody's time. Um, I hope this was helpful. I know we went a little bit long, but I think we do still have some time for Q&A, and I'm happy to stick around as long as we need to do that. And I appreciate everybody's listening and hope you got out of this what I planned. Thank you.
Thank you so much, Dr. Holzberg. So I have a list of questions here, so we can get through those. I just wanted to suggest, did you want to maybe drop the screen so
I
that
can.
you're larger on the screen?
Yeah, absolutely. Let me stop sharing.
Yeah, it's also nice for the replay. Otherwise, you end up being like a tiny
Am
little
I
speck in the
am I am
corner.
I am I better now?
Yeah, this is great. So, okay, first question here. Is methenamine safe in pregnancy?
Is methenamine safe in pregnancy? Hmm. I don't, you know what? That's a great question. I don't see many pregnant patients, so that's something that, I'm an
Mhm.
OBGYN, yes, but I'm a urogynecologist. But I would defer to looking that up and talking to their OB about it. I don't want to say for sure one way or the other. I mean, we know we could use certain antibiotics in pregnancy, and methenamine as we all know, is not an antibiotic. But I would defer to looking that up.
Okay, fair
Yeah.
enough. Do you recommend probiotics for this within your treatment protocol for UTI?
I do. I mean, I don't know if there's a huge amount of evidence, but if it can, but it for recurrent UTI specifically, if it can restore the kind of the microbiome of the vagina, yes, I do. I do recommend probiotics. And I always say to them, they always say, "What probiotic?" I say, well, I usually say, where you get your Utiva? They have a probiotic they have as well.
Oh, that's true. Yes.
So that's usually what I tell them. But I
Okay.
say if you don't want to do it that way, just make sure that it will have on the label whether it's helpful for the urogenital tract. So,
Okay. So a bit of a case question here. So okay, let me just read it out. So with the mentioned doing in-office urinalysis, even under clean, sterile techniques, there's an increased risk for specimen contamination that can impact culture sensitivity and appropriate antibiotic selection for patients. What are your thoughts on this?
well, agreed. Avoided sample, even with the best techniques, can be contaminated. That's why if it does show anything on a office-based, whether it's a dip, manual dip, or if you even have a machine that runs the UA, and it's a voided specimen, if it's negative, it's negative. If it shows anything positive, you're going to have to send it. Now, what I will tell you in all transparency, as a urogynecologist, if I get a voided UA that's positive, I'm going to do a straight cath. I mean, I'm going to examine them, do a straight cath so I can get a clean sample. Not always possible or routine in a primary care clinician practice. So I would just send it for UA. I'm sorry, I send it for a culture, and a lab UA and culture. I think that it will likely, if the culture is going to be positive, it's not going to be affected I don't think, by a very contaminated voided specimen. If the culture is positive, I'm going to see that as a reliable result and treat them accordingly.
Okay. Lately, I've been getting cultures coming back with 10 to the 7. I think that's 10 million, right? Lactobacillus. Does
Hmm.
this need treatment or is this in fact good?
That's interesting that you're getting that result without asking for it because I don't see that, in urine cultures. I don't think, no, I don't, it's considered a normal vaginal flora. So I don't think it really is something I would actually treat. Um, because it might be a contamination, right? So that's where before I treat it, I would probably either cath them for another specimen, um, assuming that it might be a contamination. It's the same when you see groupie strep, right? So groupie strep, I often will say if it was a voided specimen, is that really a contamination? And I'd rather bring them in the office and do a straight cath UA and a culture. If that's not possible, obviously then maybe you have to send them to a specialist to do that. But I wouldn't treat them until you see that on a cath urine specimen.
Okay. Let's see here. Should we consider a culture with mixed bacteria positive UTI in terms of bacterial cell count?
Now, mixed urogenital flora, if that's the same question they're asking, is a contaminated specimen. It's not considered. I would not consider that treatable,
Okay.
or in the need for treatment. You see
Okay.
that a lot in voided specimens, yeah. Which is why I'm a big fan of getting cat specimens. But again, I know that's not always realistic in a primary cares practice.
Yeah. Okay. Let's see here. Um, I'm just reading through them all, just in the interest of time.
Yeah.
Uh, how effective is vaginal estrogen in non-perimenopausal women with recurrent UTI?
In non-perimenopause, and
Yeah, so
asking,
this is kind of like I think like an
so
outlier
like
of a
a
question.
premenopausal patient?
Yeah,
I mean, if they're premenopausal, they should likely have enough estrogen, right? In their system and within the urogenital area. So it probably, is not going to be hugely helpful. I don't think it's harmful. Um, but I don't know how helpful that would be. I'm not sure it's been studied in that population.
fair. Makes sense.
Yeah.
Um, what is, well, when you're recommending Utiva, the cranberry packs or UTI control, what is the duration of treatment? Or how do you typically recommend patients take it?
I mean daily. Um, and to be honest with you, in recurrent UTI patients, I would say indefinitely. There's no harm to that, and I don't think the majority of patients that will do it indefinitely, the ones that have responses, which that 26% or give or take, that have significant reductions are going to likely take it forever, right? The
Right.
ones that feel like it's not working as well certainly aren't. But I do it daily and definitely there is some recommendation of taking it, taking two capsules, after relation so that I give them the pamphlet that Utiva provides that gives them
Yeah.
other ways that it can be taken. But I do recommend them to take it daily. And we didn't really talk much about the fact that I have patients all the time that say, "Oh, I drink cranberry juice," and I say, you would have to drown in it in order to be effective. And all the sugars that come along with it is certainly not what you want to what you want to promote as well. So
Right. Yeah, that's a good point because
yeah, it
it's
was a point
not
I didn't
the
make, which I wanted to make. There might be some packs in cranberry juice, but not enough, and there's so much sugar that comes along with it. Okay, you can buy non-sugar cranberry juice, but anyway, the capsules are by far superior. So I tell a patient, you basically have to drown in cranberry juice for it to be
And I
helpful.
think just understanding that it's not treatment, it's
Right.
prevention,
It's prevention, correct.
right? So unless
Yep.
the underlying cause has somehow been removed or fixed or treated or healed, that prevention's always going to kind
Yep.
of need to be there.
Good point.
Let's see. Okay, maybe we'll do two more questions. Is that okay?
I'm good.
Okay. Let's see here. Okay.
I know everybody wants
Suggestions
to know.
for
Good.
some I like sometimes these patient-specific questions too,
Yeah,
because
that's
it can
okay.
help someone out. Suggestions for treatment in an elderly woman with a large renal stone that is asymptomatic, but urinary pathogens are related to stones. She's a post-surgical candidate. Does that make sense to you?
So I followed it, but then lost you. So,
Suggestions for, yeah, treatment in
oh,
elderly women with a large renal stone, which is
gotcha.
asymptomatic, but I think the pathogens in her urine are
Gotcha.
related to stones.
Gotcha. So I do not treat asymptomatic patients. Period. Uh, Bacteria positive cultures or not. If and that's basically the recommendation. If they're asymptomatic, that's why symptomatic, it's not negative culture that's a cure now in the 2025 AUA guidelines. It's symptomatic relief is the treatment. So if that's why when I see patients in the office, um, recurrent UTI patients that come in for follow-up and they say they're having no symptoms, the first thing they say to me was my urine negative? And I'll say, I didn't test the urine. Oh, but I left the specimen in the bathroom. And I'll say, I didn't test it. I said, why do you want me to test it if you have no symptoms? Well, I want to know if I have a UTI. I'm like, it doesn't matter. You have no symptoms. You don't chase after a culture. Chase after their symptoms. They can be colonized with that E. coli, right? It can be living in the way I described that microbiology. You don't have to treat that. You want to treat their symptoms, not their result.
Okay. And let's see, final question here. A lot of questions on um, like not symptomatic, but the urine tests
Yeah,
are,
don't treat
it,
them.
yeah, it's
Don't treat them. Don't
interesting.
treat them. Don't treat them.
Let's see. Okay, is it helpful to use Utiva concurrently with antibiotic use?
Yeah. I mean, I don't recommend them stopping if they're on antibiotics, I don't, again, cranberry is not an antibiotic, right? It's a prevention strategy, like Yoti said, so there's no reason to stop it when they're taking an antibiotic. It doesn't have any effects on the absorption of the antibiotic.
Okay. And Dr. Holzberg, I just wanted to ask you one more question just because it's come up a few times here. Just the idea of recommending vaginal estrogen for women who, there's a concern with breast cancer. How do
Yeah.
you approach that?
Yeah. So a concern if they have a history of breast cancer.
Yes.
Yeah. So, that if you talk to more progressive oncologists, they will be fine with vaginal estrogen in breast cancer, especially if the absorption of a half a gram twice a week, which is what I usually give, or some give a gram twice a week, but the absorption of a half a gram to a gram of vaginal estrogen 2 times a week into the systemic circulation is negligible. So I know that many, but the problem is the patients usually the problem is if they get a recurrence in their breast cancer and you had them on vaginal estrogen, they're going to think it was because of that vaginal estrogen, right? And they're going to think they did it to themselves, and they're going to feel like, oh, I can't believe I gave myself breast cancer, So that's the problem. You some will be okay with it and they'll be understanding that even if they get a recurrence, it wasn't due to the vaginal estrogen, right? It was due to the recurrent nature of breast cancer, right? So that's what you have to think about, but I will often defer to their oncologist because I don't want to do something that the oncologist doesn't want me to do. So I'll
Right.
say, look, in my opinion, it's safe, but please talk to your oncologist. If they're comfortable with it, I'm comfortable with it. If they don't want you to do it, I would defer to that.
Okay. Makes sense.
Yeah.
Okay, well, I mean, we could go on and on and on, but I think
Yeah.
we'll have to cut it
I
off at
I
some
uh
point.
I more look forward to the comments of whether people enjoyed the talk. So I hope
Yeah.
it was helpful and I hope Jyoti, if you could share the comments with me, that'd be great.
Yes.
Um,
We have a
Always love,
survey
yeah, the
afterwards.
survey. Yep, yep.
Yeah.
Always love doing this. Appreciate the invite. And it was wonderful to be able to meld these two topics together. So I think it's great.
Yeah, thank you so much, Dr. Holtzberg.
All right. Well, I'm not a candidate for the Amazon gift card, so I guess I'll sign off
Yeah.
now.
Yeah, for everyone else, just hang on because we're going to do the raffle. But thank you so much, Dr.
Yep.
Holtzberg.
Thanks, everybody.
Take care.
Bye-bye.